well, I've got 3:02, so why don't we get started? Welcome, everybody, to the Texas Epidemic Public Health Institute Grand Rounds. Today, we're going to be talking about antimicrobial resistance. But before we get started, let me tell you, for those of you who may be new and don't quite understand what TEPHI is about, let me show you a little bit about us. We are a Texas state agency committed to keeping Texans safe and the economy strong by improving capacity and resiliency to respond to future infectious disease outbreaks. We're housed within UTHealth and have a lot of partnerships with other entities involved in preparedness planning. So some of the things we offer, one is our Pandemic Preparedness Certificate Program. This consists online, free to Texas residents, asynchronous, of 4 courses plus a tabletop exercise. If you are interested, the website's right there, and as well as a QR code. We offer CE credits for this, and as I said, it's at no cost. You can do it at 3 in the morning if that is what you would like to do. We also have ancillary to that some mini courses. These are 1 to 3 hours, again, online, free, asynchronous. We have, as you can see, some available now and others that are going to be coming very soon. If there are topics you are interested in, please let us know. And I realize I do this every time. I forgot to introduce myself. I'm Kathy Troisi. I am on the faculty here at UTHealth School of Public Health and also involved with TEPHI. We also offer CE credits for those mini courses as well. So here's a slide showing how you can connect with us. But really, you can find all of this stuff at tephi.texas.gov, and we'll show you that website again. For the webinar, we are going to be recording. I don't think we start. Dana, could you start that, please? If you have questions, put them in the chat. I'll be monitoring it, and we'll ask them at the end. Again, please complete the survey. You have to complete the survey if you want continuing education credits, but we're also interested in evaluation from everybody. Let us know suggestions. Our next talk will be January 13th at 3 o'clock Central Standard Time. I am thinking about doing Marburg virus, but if there are other topics you're interested in, again, let me know. And this is being recorded, be mailed out in about a week, and you can find previous Grand Rounds at our YouTube site. Again, you can find all of this on the tephi.texas.gov website. So it is my pleasure to introduce our speaker for today. Dr. Hanson is an assistant professor here at UTHealth School of Public Health. He is also in the Center for Infectious Diseases. His laboratory uses a combination of existing and innovative laboratory techniques and cutting-edge sequencing and bioinformatics to study infectious disease transmission and colonization, how microbial communities impact the development of disease, and how antimicrobial resistance develops and transmits through society. He's also a member of TEPHI, and I don't know if he's going to be talking about this today, but does a lot of wastewater work as well. So Dr. Hanson, thank you. I will stop sharing and let you take over.
Thank you very much. Thank you for the fantastic introduction. Let me get my slides set up. Just give me 1 second. Right, and then there we go. That works. Awesome. All right. Thank you again. So yeah, we're going to go through a lot of topics today about antimicrobial resistance, how we think about this from a public health point of view. And many of these topics on their own could be grand rounds. So as Kathy mentioned, if there's things you're interested in seeing, include some of these topics if you'd like to see more of them come up or deeper dives into each one of them. Before we get into that, I do also want to, just because we have the continuing education credits here, I do not have any disclosures. I have no financial stake in any of this. This is all information that is available to you all and publicly available as we go through. And so just to start this out, I want to kind of give a sense of where we've come from. And so this is Alexander Fleming. And Alexander Fleming actually is the individual who identified penicillium, the fungi that has penicillin, that is kind of our first biologic antibiotic that came available. And this was in 1928. So this is a little over 100 years ago. We've really only had antibiotics available for treatment of infectious diseases, infections, and things like that for about 85 to 90 years. And Alexander Fleming is the kind of stereotypic example of the dirty scientist. You can kind of see it by the piles of plates sitting behind him. But he studied Staph aureus and was a pretty prolific researcher, and left on holiday, left his window open, hadn't cleaned up after himself, and left some plates sitting out that he intended to clean up when he got back to his lab after his vacation. When he came back, he found that he went to go look at his Staph aureus plates, expected to see a lawn of the bacteria that had grown across them, and saw that lawn, but in the middle was this big white fluffy ball, and around that ball was this zone, which we all now refer to as a zone of inhibition, where there wasn't any Staph aureus growing into. And this piqued his interest and really started to kind of get him going. And he was able to identify the penicillin was an excreted factor that was able to kill Staph aureus, which was what was on that plate, was able to start to go through, but had a lot of issues with kind of taking this to the next level, being able to purify enough penicillin to become something that they could test for clinical applications, but is the one that we credit with the identification and discovery of this a little over 100 years ago. And this then became something that sat from about the late 1920s, early 1930s, until the late 1930s, where Boris and Chain picked this up, and it became a massive effort to learn how to produce this at high enough levels. It became a part of the wartime effort for the Allies in World War II as a way to keep our soldiers healthier, and was actually a war secret, and really only became available to the public in 1945 in the United States, Europe, parts of the other world, 1946, and later. And became a massive change in the way that we think about infectious diseases and how kind of deadly they can be. And so this is an advertisement from a trash can in 1945, 1946 that is advertising that penicillin can cure gonorrhea in under 4 hours. And this would be one treatment, you're cured, and you can move on. And this really kind of kicks off the indication of how much of a change this was. And it led to massive reductions in infectious disease mortality. And so you can see here just a few of these estimates. And I will say that the death rates with antibiotics are from the 1960s and 70s intentionally. These are not what we would see today, because we've had other benefits and kind of improvements in our clinical treatment. But you can see that before the onset of the antibiotic era, community-associated pneumonia had a mortality rate or a death rate of about 35%. With the onset of antibiotics, we saw that this had been reduced down to about 10%, and that leads to a reduction of about 250% in the proportional death. And so if we were to then lose access to antibiotics, we can see this increase up to 250%. And for things like bacterial endocarditis, which is heart infections, those had a roughly 100% mortality rate before antibiotics were available. This was reduced down to about 25%. And so we saw this massive, massive decrease in effectiveness of antibiotics. And if we compare this to things that we think of in terms of chronic disease, like treatment of aspirin or clot-busting drugs to try to prevent secondary heart attacks after the initial heart attack, the early studies from the 1970s and 1980s of this intervention showed between a 3% and a 9% reduction in the onset of a second heart attack or other cardiac event due to the onset of aspirin. And so you can see how different and how drastic the impact of these antibiotics were on just treating infections alone. But their utility is not only infections. We can also see that these took things like routine or like surgeries that before had a high mortality rate associated with infection, and they've become routine, where we see that the vast majority of individuals never experience an infection because they're given prophylactic antibiotics to try to prevent and head that infection off. And so you can see this is used in things like organ transplants, generalized surgeries. It's used with on individuals who are going through dialysis, cancer care, a number of chronic conditions like diabetes. This is a massive change of how we think about medical care and has enabled a lot of what we see as routine care today. But impactfully, when we use antibiotics, it doesn't continue to have the same effectiveness over time. This is something that bacteria have been experiencing for a long time. We're using penicillin from that penicillium fungi, which is part of microbial warfare. It's how the penicillin makes sure that Staph aureus can't get near it. It makes sure it still has the nutrients it needs. And so bacteria are used to seeing antibiotics in some form or another and can develop resistance to those antibiotics, reducing or eliminating the effectiveness of those antibiotics. And there's a lot of different ways that they can do this, but this can be through things like changing the target that the antibiotic looks for so that it no longer looks the way like the way the antibiotic can affect it, creating ways like porins and efflux pumps to try to kick the antibiotics back out of the cell, changing the way that that antibiotic gets into the cell. And all of these lead to an idea of functional resistance, which is when you can give the antibiotic, but it isn't enough to kill the bacteria that you're targeting and doesn't treat that infection. And across time, you can see again, we have 1941 that was penicillin was released. This is wartime effort. It was widely available in 1945. You can see that within a year, we start to see penicillin-resistant Staph aureus, which makes sense. And we can see that we have penicillinase producing Neisseria gonorrhea, which is that gonorrhea causing pathogen, by 1976. And for every one of our antibiotics that we have released, we have observed resistance, often on a less than 2-year time frame. And the more that we use our antibiotics, the more that we give them to people for treatment, the higher the chances are of this resistance developing, and the higher the chances are of that resistance then disseminating into our population. And so unlike our chronic disease medications, things like Lipitor for blood pressure, unlike those medications where you can use them over and over and over again, and they continue to be as effective as they were when they were developed, antibiotics have this unique aspect that as you use them, on average, they can become less and less useful because of this emergence of this resistance. So you no longer treat gonorrhea with penicillin because it doesn't have effectiveness at a wide enough scale to be useful as an antibiotic for that pathogen anymore. And so this has led to, in under 100 years, coming up to a situation where now we have a number of these resistant pathogens that the CDC classifies across multiple levels. And you can see here within the urgent threats category, we have drug-resistant Neisseria gonorrhoeae, which causes that gonorrhea again. And this specifically is because there are now strains of Neisseria gonorrhoeae circulating within our population that are pan-resistant, meaning that there are no more antibiotics available to treat this pathogen and treat this infection. So in aspect for those individuals who have that specific pathogen causing an infection, we cannot treat them with antibiotics. We have to look to other methods of treatment. And it's something that we want to make sure that we limit or eliminate as much as possible to keep the utility of the antibiotics available to us. And I think I've said it enough, but I really want to highlight this point of how impactful antibiotics have been. And if we go back and we look at the top causes of mortality in the United States in 1900, you can see that 4 of the top 5 causes of mortality are infectious. I'm sorry, 4 of the top 10 are infectious. We have pneumonia, tuberculosis, diarrhea and enteritis, and diphtheria. And these are things that are addressable by antibiotic availability, improvements in vaccination, things along those lines that have caused a massive change. And so if we look to the top causes of mortality last year, so 2023, you can see that the only infectious cause of mortality in the top 10 now is COVID-19, which is all of us have lived through, is an emerging pathogen that emerged in late 2019 and was actually number 2 for 2020, 2021, and has continued to come down as we've developed better treatments and had kind of more experience with that pathogen. And so we've had an incredible impact, and we've reduced the impact of these antibiotic and vaccine treatable or preventable infections, but that does not mean that they're not still there. And so within the United States in 2019, we saw that an estimated 2.8, almost 2.9 million infections were caused by antimicrobial resistant pathogens and almost 36,000 deaths. And these are both likely underestimates, particularly the deaths that are listed here because these are caused by the resistant pathogen. This is not associated with the resistant pathogen. So if someone has, say, late stage cancer and they're in the hospital and they get an infection with a resistant pathogen, it may contribute to their death, but it doesn't cause it because that late stage cancer is considered that primary cause. Those aren't listed in these numbers. So these are likely underestimates of what the true burden is in our population. And recently, there's been a lot of effort to try to understand that underestimate and try to then look to see what the future may look like. And so in about 2014, there was a report put out in the UK that was projecting global causes of mortality. And they were projecting that by 2050, antimicrobial resistance and the pathogens that carry it would go from not being in those top 10 causes of mortality, but globally would then go to back in the top 10. And in the worst case scenario of what they were projecting, would cause almost 10 million infections and deaths a year globally, and would become the #1 cause of mortality annually. And we've done a lot of work since 2014 to try to address this. And so there was a lot of kind of promise, and people didn't feel that this was what we were heading to. And I still don't think this is what we were heading to. But with the COVID pandemic, and I'll come back to this in a little bit, there were some challenges that we ran into. And so a recent WHO report basically forecast that there would be 39 million deaths by AMR pathogens between 2025 and 2050, and that in 2050, we would see 1.91 million deaths attributable or specifically caused by these resistant pathogens, and 8.22 million deaths that are attributable to these pathogens that have some association. And so we still have a lot of work to do. And if we start looking at this across the globe, this is not something that has an equal representation globally, and is not something that we see an equal risk in all parts of the world. And so you can see here within the US, if we look at our current mortality rates caused by resistant pathogens, we're sitting roughly in that 6 to 9% category. And a lot of this is being driven by the elderly or individuals who are immunocompromised. But there are parts of the world that have much higher rates of mortality associated with these pathogens. And if we look at what the current projections are for 2050, you can see that we are jumping up in the United States to 15 to 18%, almost doubling in that capacity. And other parts of the world see these mortality rates come up much, much higher. And similar to the geographic disparities that we see within this, there are also age differences that are present within our current data and within the projections of what we're seeing coming in the future. And you can see that a lot of our current burden is within our individuals that are 50 years and above, with primarily being driven in those individuals who are 70 and above and are vulnerable elderly, particularly people in long-term care facilities, people in hospitals and environments like that. But you can see that this massive increase is occurring. And this is actually driven around the COVID-19 pandemic and a lot of the challenges we encountered with that in terms of hospital preventionism, good hygiene methods, and things that I'll come back to in a little while. But one thing you might notice here is that we actually see a reduction in our youngest population, our individuals under 14 years of age, but really being driven by individuals who are under 4 years of age. And when we start to look at this in a different way, you can see that the green bars here are from 1990, and these are the attributable mortality or deaths associated with resistant pathogens in 1990. And you can see that we have the associated and the attributable on each side here. And then we are also projecting 2021 here over the top of it in blue. And so you can see we have a large reduction in resistant pathogen-associated deaths in individuals under 5 years of age that is offset by that larger grouping in our elderly population being hit. But these gains that we have in this reduction and these large efforts that have been made are really attributable to increased availabilities of vaccines, such as pneumococcal conjugate vaccines that address things like pneumococcal disease, which is a massive cause of mortality in children under 5, particularly worldwide. Availability of the diphtheria, tetanus, and pertussis vaccines, as well as massive investment in water, sanitation, and hygiene infrastructure globally. And as a kind of a little bit of an aside here, I had the pleasure of having a very, very minor role in a Gates Foundation funded project looking at the effect of the pneumococcal conjugate vaccine 7-valent version, so PCV7, in the Gambia during my postdoc. And this was a really interesting effort because what they wanted to see was that this vaccine had been developed in Europe and North America based on the strains of pneumococcus circulating in those populations. And they wanted to make sure before they started to roll out vaccine initiatives that these strains covered what they were seeing within the Gambia on Western Africa's coast. And so as they went through, the Gates Foundation worked with a number of groups, and they decided to go through and have randomization of villages into vaccine statuses. And so there were their unvaccinated individuals, which was just the general individuals who were existing as it was in that time frame. They had villages where they would vaccinate the infants themselves only. And then they had villages where they would vaccinate the infants, the mothers, and the siblings as an idea of ring vaccination around these children. And what they found was that it was so effective in reducing mortality rates in both the villages with vaccination of the infants and the ring vaccination villages that about 6 months into the study, the government of the Gambia came through and vaccinated everyone in about a week and a half and implemented a massive change. And they saw the amount of infant mortality due to pneumococcus infections precipitously dropped and showed the effectiveness of this. And it went from being I think it was the number 2 cause of mortality in that country at that time frame out of the top 5 within about a 1-year period. These are incredibly impactful things, particularly when they're coupled with water, sanitation, hygiene, infrastructure investments. So there's promise here, and there's things that we can do and that we know how to do and we know how to do well. And I don't want to minimize the human aspect of this. There is a massive human cost to antimicrobial resistant infections. They're debilitating. They're very tough to get through. If anyone's ever had them, they're very rough to work through, as any infection is. But there's also an economic cost that we need to look at. And so you can see here, this is the economic cost of antimicrobial resistance as projected by the World Bank. And this is projecting their own version of similar data, what we looked at for those 2050 timeframes. And they broke this down into a low AMR scenario and a high AMR scenario. So the high AMR scenario is very similar to that 10 million deaths a year. The low AMR scenario is about doubling what we're seeing today. And you can see that this would be the impact of the amount of reduction in gross domestic product based upon the onset of this emergence of these different pathogens. And for those of you who, like myself, remember the 2008-2009 financial crisis in the United States, this was the impact of the 2008-2009 financial crisis, which sits about in the middle between those two different scenarios. This would be a very massive impact on the global economy. And for those of you who are not old enough to remember the 2008-2009 financial crisis, if you look towards the COVID pandemic, particularly in 2020, when we saw a lot of the stay-at-home orders and things like that, that had a negative impact on our GDP of the United States of about 2.21%. So again, that would be sitting right here and right in between these two different scenarios. What makes this different than the financial crisis, than the COVID pandemic in the way that we experienced it, is that this would not be a transient 1-year reduction. This would be a sustained year-over-year impact of the loss of this GDP, which would lead to a large challenge to our economies and our governments. And also, even more than that, coming back to that human cost, would be a large challenge to our healthcare system and our infrastructure, and would increase the cost of healthcare, particularly end-of-life care, incredibly, and would strain our systems as we have them today. And so that's a lot to get us to this idea of kind of where are we currently. And I would say that's very much kind of the belly of where I think we're going to be. I feel strongly that there's a lot of effort and kind of innovation being put into addressing this challenge currently, but it is something that we need to take incredibly, incredibly seriously. So how are we doing that? So there have been a number of reports. This actually references to the WHO on the bottom, but there's a lot of different ways that this is being tackled and a lot of different efforts that are coming through, but they tend to be bucketed into about 6 different groupings of information. And so the first thing that we can do is to improve awareness and understanding of antimicrobial resistance. The second one that we can do is to strengthen our knowledge and preparedness through surveillance and research. And this is really driven by monitoring. We saw in the COVID pandemic how impactful it can be when you understand what variants are circulating, how those variants may associate with specific medications. And so if you think about the monoclonal antibodies that were taken off the market with some of the XBB emergences that happened, you can think of similar things. If you start to see the emergence of resistance mechanisms and resistant pathogens at a certain level, that may then guide you to use a different antibiotic than what you would think would be effective when you have that data at your fingertips. We also then want to reduce the incidence of these resistant infections through effective sanitation, hygiene, and infection prevention. We want to optimize the use of our antimicrobials in human and agricultural use. And this is something I think most people don't think about, but we use our antibiotics in our agricultural system as well. And I'll come back to that a little bit more in a little bit. We want to make sure that this is sustainable and the investment is sustainable at a global scale. As we talked about with the global map, this is not something that is siloed to just the United States, to just Europe, to just parts of India, Africa, South America. This is not something that is unique to one location. This is a global problem. And it is something that resistant pathogens can pop up in one part of the world and then be transmitted to another part of the world. And so we need to know what's going on globally to understand and anticipate what's happening. Again, very similar to when we saw the emergence of new lineages of SARS-CoV-2 in South Africa that then spread across the globe and we had a major strain shift event. Those are the things that we can do with antimicrobial resistant pathogens as well. And finally, we want to strengthen our policies, our legislation, and our regulation to support all of those efforts above and make sure that that's consistent across time. So we have this massive global effect and this global aspect, but I want to focus in on just what the US specifically has put together as their national action plan. And this was put out in 2015 and has adapted across time. But they broke down the US action plan because this is the policy and the legislation part. They broke this down into 5 pieces that cover the other components of what I just showed you. And I'll go through each of these individually over the next 15 slides or so to kind of really introduce what these concepts are and show you details about them as we continue through. And the first one of these is that the National Action Plan aims to slow the emergence of resistant bacteria and prevent the spread of resistant infections. So how do we do this? Well, I think first and foremost, we want to educate healthcare and public health professionals and make sure the public is aware of what this is. So I want to thank you all for coming. This is a big part of these efforts is things like this, where we have large turnout. What do we have? We have 179 people here right now that are all watching this. So thank you for being here. This is how we address this pandemic. And it's through making sure people understand what is going on with this. As a part of this, I want to just mention that every one of my slides has a resource at the bottom of it that are all very freely available publicly available public health, high quality references that you can go and look at if you have specific questions, you want to follow up on pieces of this. And I've got some other high quality references here that I want to call out. And so we have a lot of resources that the CDC has put together that are incredible, the WHO as well, and they often have slightly different takes on them, but it's the same underlying concepts, and both drive a lot of our knowledge of what's going on in the world, what's going on in the United States, and the initiatives that we undertake as a part of addressing this pandemic. I want to also direct you to the national academies. And in particular, there was a workshop that happened this last spring, but there's now a video of this online that has a number of different pieces that I think are really well addressed. In particular, some of the challenges of estimating the number of these infections in a population and how you start to do that at a local level. How do we address antibiotic use in our agricultural systems? This is a really nice 2-day workshop that the videos are available and I think is a great resource. And the National Academies continues to update these resources over time. And then for our clinical partners that are in the audience, I want to highlight one of, but not the only one of our professional organizations, which is the IDSA or ID Society of America, that has a number of guidelines on how to address antimicrobial stewardship, how to go through and offers specific guidelines on antimicrobial prescription options, durations, and how to approach specific pathogens and specific infection manifestations, particularly when you have that added challenge of antimicrobial resistance. So please use the resources that are throughout here. I think that they're incredibly valuable, and I'm only touching the surface of this because of how big a topic this is. And again, as we go through this, if there's something you want to see more of, please drop that into the TEPHI, suggest a talk piece, and see if we can't bring some of these more up and go more in depth on some of these specific topics that are of interest to you all. So next up, when we're trying to stop the emergence and prevent the spread of these different pathogens, is this really fundamental idea of antibiotic stewardship. And there's a lot of nuances to this. And this could be something that we could go into each one of these independently, but I want to just cover the broad strokes of this. And the whole idea of this is to promote the rational use of antimicrobials. And rational means giving an antibiotic when it is needed, but not giving an antibiotic when it is not needed. And I'll come back to this in a few slides. But an example of when we see a lot of antibiotics prescribed when they are not needed is when someone has a viral infection. And antibiotics don't work on viruses at all. And so we don't need to give antibiotics when someone has a viral infection. We need to give other types of medical treatment. But we see that often people are given those antibiotics due to a number of reasons. We can also look and see it's about giving someone an appropriate antibiotic. If someone has penicillin-resistant gonorrhea, you don't want to give them penicillin. That is not an appropriate use of the antibiotic because it's not going to work and treat them. So there's a lot of different places that this goes. But again, this is impactful in inpatient medicine, so our hospitals. This is impactful in our outpatient medicine, our clinics, our emergency rooms, your general physician that you go see, and in veterinary medicine, both in animal production and in treatment of infections of your companion animals, or in the swine herds that provide our food, all sorts of different places. And this is something that becomes very, very important when you look at the scope of this. So if we look at just this idea of appropriate versus inappropriate antibiotic use, you can see on the left-hand side here, we have the number of prescriptions of antibiotics dispensed per 1,000 people in each state in the United States. And you can see that some of these states are bucketed into a group where there are more antibiotics given each year or prescribed each year than there are people in that state. And not to call them out, But West Virginia is usually on the top of that specific list, where they are getting on average 1.2 antibiotics per person per year. And that's a lot when you think about the number of people across the United States. And then when we start to look into this further, at least 30, and some of these estimates approach 45 and 50% in some subpopulations of these antibiotics are not necessary prescriptions. They are given when they're not warranted, when they aren't medically needed for a number of different reasons. But it comes a big place where we can start to focus in on reducing the amount of antibiotics given, because when we give less antibiotics, we have less chance for that resistance mechanisms to develop and less chance for them to spread throughout our population, and it preserves the utility of those antibiotics for the future. And this is on the clinical side. There are a lot of reasons as well why patients want antibiotics, and it's mostly driven by patients want to feel better, and antibiotics we have come to expect make us feel better. But there are a lot of things that drive our suboptimal prescribing, and these are a number of different of kind of categories, and it runs the gamut of different reasons. Things like fear of insufficient antimicrobial coverage. Well, I want to give these antibiotics because I'm not sure if I gave a different one, if it would work effectively. Or it can be gaps on the knowledge about antibiotic effectiveness and new guidance. Maybe they don't know about the emergence of a new resistance mechanism. They don't know what the guidance is for treatment in that specific environment. And this is challenging. Often when we look at things like urinary tract infections, defining a urinary tract infection is incredibly hard, particularly in catheterized individuals and in our elderly population. So we often give antibiotics or not, depending on kind of some of the guidelines that may not be totally up to date for everyone that's paying attention to them. It can also be sometimes challenging to recognize the link between antibiotic use and antimicrobial resistance because they feel disconnected. When you give a patient an antibiotic, you want to see them get better, and often they do. But that you can't see at the same kind of transparent level that they may get better. But now that pathogen that they were infected with is still in their microbiome. It's still living in their gut. It's living on their skin. But now a small subpopulation has become resistant. And the next time they get that infection, then it's going to be resistant. Or they may give it to someone else who then has that resistant pathogen and transmit it. And it could be things like reluctance to change established practices. We've been doing this for a long time. We don't want to change. It's worked for a long time. Why would we rock the boat? But that's often difficult to overcome. And just because it worked in the past does not mean it will work in the future, particularly as new information and new guidance becomes available. There's sometimes a belief that their patients are unique and they want to make sure that they give their patients as much as they can. And I think that's a really admirable thing within our clinical fellows and our clinical settings, but it can be a challenging thing to overcome. And the last one is just a lack of institutional stewardship efforts or a disinterest in them. And there's been a ton of effort and a lot of federal guidelines over the last decade mandating the use of antimicrobial stewardship that's now starting to move out into our long-term acute care facilities, which I think is a massive benefit, again, aimed at heading off what we think may be coming with that 2050 number. Oop, too far. Oh, maybe. Okay. And I think the other one here, and this is a big piece of this, that there are some incredible groups in the United States that do this work. And there are teams at every hospital that focus on this. And we need to strengthen our infection prevention and our control measures. And we have incredibly strong research and evidence-based guidance on infection prevention and control. Everything from washing your hands, the availability of hand sanitizer in certain settings because people are more likely to use the hand sanitizer than they are to wash their hands every 2 minutes. Availability or things like what order you touch a patient in to make sure that if they have an infection or they have a dirty site, you don't introduce that into a non-infected site. All of these things are things we know a lot about and are continuing to learn about and continuing to expand. The challenge that we see, and a lot of what we've seen with the COVID pandemic and that blip and then the increase that we see in our trajectories is due to kind of the challenges that existed in maintaining our infection prevention and control measures in our hospitals and in our clinics during the COVID-19 pandemic. And this was due to shortages in gloves and PPE, challenges in staffing your facilities, all of those. But you can see that when we look at our urgent and our serious threats from those CDC lists, from 2019 to 2020, we see an increase of many of them. 2020 to 2021, we see an increase again. Some of them start to stabilize out. And we're seeing these procedures start to come back in 2021 and 2022. But if we compare that to the 2019 eras or data, we still see that these are an increase in the rates of these infections, many of which were on a decline before we had the COVID pandemic come in. And so I think this is one of the bright spots that I see is that we look at those numbers and those trajectories. I think with the reintroduction, reestablishment of these infection prevention and control measures, we can continue on the trajectories we were on before and hope to reestablish that kind of projection that we had. But it requires effort and vigilance and keeping on top of these and making sure we stay up to date on the evidence-based guidance that we are receiving as these new pathogens emerge and these new things continue to evolve across time. And so what about the second aspect of our national action plan? So this is strengthening national One Health stewardship and surveillance efforts. So what is One Health? So we often think about as humans that we have human infections and those are ours and that is kind of our own little bubble. But in reality, similar to how pathogens don't know what a country boundary is, they also don't know for a lot of these, what a species boundary is or what a boundary is between us and our companion animals. And up to 70% of all the different pathogens that infect humans also can be carried or infect other animals around us. And this can be, like I said, our companion animals. This can be our domestic animals that are agricultural settings like cattle, like chickens, like pigs. And this also then bleeds into wildlife like deer and then continues into our environment around us, as well as the reservoirs are sometimes the water sources around us, our fields where we're providing manure. These are all a part of our web around us. And this is this idea that it's not just a human health problem. It is part of animal health and it's part of a larger thing around us. And that's an impactful thing to start to think about when we think about antimicrobial resistance, because as I mentioned, a large portion of antibiotics are used not for human consumption, but for animal consumption. And I tried to find updated statistics from today. All I could find were statistics from 2016, so I haven't included them as a slide here. But in 2016, and there's been a lot of effort starting in 2017 to change this, we saw that about 60% of all antibiotics consumed annually were consumed by animals. And so it was a large portion of our antibiotics on a tonnage scale were not human specific, and that creates a whole different world that we have to think about. And so if we think about our production animals, our cattle, our chickens, our pigs, what we see is that they often get antibiotics as growth promotants or as prevention for infections as a part of our production cycles to keep them healthy as they're growing up in the facilities that they're grown, areas that they grow in. And so as we go through what they get these large number of antibiotics, we can see that just like sometimes these resistant pathogens emerge in humans, you can see that some of their microbiomes, some of their pathogens can also then start to develop resistance to these antibiotics, which can then spread within our animal herds and then sometimes jump over into humans as well. And this can be due to things like jumping into the workers that are around them, through our food production facilities, or most commonly, we often take the manure that is produced by these animals and turn that into fertilizer, which is then spread across our fields to fertilize and restore nitrogen and other things to our fields for crop production. And those bacteria then maintain on our food and end up causing foodborne illnesses, get into the population that way. And so it's a much more holistic view of what we need to think about when it comes to antimicrobial resistance, emergence, and antibiotic use. And it's very, very important. And I mentioned that we had this kind of change in 2017. And so the FDA in 2017, actually as of January 1st, mandated that there would be judicious use of antimicrobials in food process and that they remove the production use of antimicrobials that they call medically important, which means any antimicrobial that is used for human treatment or has a similar class that's used for human treatment cannot be used for growth promotant or infection prevention. You can still, however, use them under veterinary oversight to treat infections in our animals. Again, we want to balance that, and animals get infections too. So we don't want to just exclude antibiotics. We want to be thoughtful about the way that this works. And you can see a large reduction in the amount of antibiotics used that were considered medically important in 2017, but it's kind of stagnated from there across time. And so there's still work to be done here. And a part of those National Academies presentations, there's a fantastic talk from someone who's involved in the chicken production facilities about what the balance is and where they're trying to make this work, because we have to balance the needs of the animals and the quality of life and preventing it and treating infections with keeping these available and useful for human need and human use as well. So what about the third aspect of our national action plan? So this is, I think, one of the more interesting ones from a technological point of view, but I'm going to spend the least amount of time on because it is very technical in nature. But this is to advance the development and use of rapid and innovative diagnostic tests. And there's a ton of cool work going on here. And I will say, this is not a promotion. I am not advocating for these devices, but this is one of the examples of our newest kind of emerging technologies. And I've mentioned that when you have a viral infection, you do not want to take antibiotics or give antibiotics to a patient with a viral infection because they do not work on viruses. They are specific to bacteria. The same way that an antibiotic is not going to work on a fungi, you want to give them an antifungal. Those are important distinctions. But when we think about respiratory infections, think of pneumonia, it's often difficult, even with x-rays, to differentiate between viral and bacterial pneumonia. So there are these new tools and these new systems that are coming out that can rapidly, 10 to 15 minutes, differentiate between viral and bacterial infections based on host immune responses, because we can't tell, but our body knows. And our immune response is different if it's a viral infection or if it's a bacterial infection. And so these specifically go through, and this one is a laminar flow assay. So think your home COVID test. It's a very similar aspect. You then add in the sample from the individual's blood, and you go through and you look and see what the immune markers are, and it will say, yes, this is most likely viral or is viral, and yes, it's most likely bacterial or is bacterial. And then you can use that rapidly to guide treatment efforts. And for those of us who go into, the clinic, if you have pneumonia, for bacterial pneumonia, you want to give them an antibiotic immediately. I've had pneumonia 4 times in my life. You want an antibiotic. It's an awful feeling. You feel much better right away. But if you have viral pneumonia, you want to treat that in a different way because that antibiotic's not going to be effective. So as a consumer, as a patient, this is something that gives us information and gives us assurances very rapidly. And we're starting to see these roll out in clinical care. And I think are going to change a lot of the way that we think about clinical care and also hold a lot of promise from an antimicrobial stewardship point of view. And this is the only slide where I'm going to kind of promote my own work and my own aspects of what we do here, but there's also a lot of emerging technologies to identify and characterize resistant pathogens as a mechanism of understanding what resistance mechanism are they carrying? Are these expanding in our population? Think the way that we've tracked COVID-19 and SARS-CoV-2 across time. We're starting to see these come up as we've had massive improvements in our genomic infrastructure globally over the last 5 years. And what this does, and this is my tool on the right that my lab develops, called GenoStellar. And this is kind of us walking. I want to get to the point where I can actually start to kind of run and fly, but we're walking at this point. We are building towards a clinically and epidemiologically actionable tool, but you can take a genome sequencing data from a Klebsiella pneumoniae sample, upload this, and in 7 minutes have molecular epidemiology markers, information on what resistance mechanisms it carries. And the next version of this that we put out will allow you to compare it to other isolates coming from your own clinic, your own hospital, your own site, to start to understand and track variation across time and see if you have consistency of things you don't expect to see, which might be indicative of transmission within your population. So the fourth aspect of our action plan is to accelerate basic and applied research and development for new antibiotics, antifungals, and other therapeutics and vaccines. And this has been a massive point of focus for places like the NIH, the WHO over the last 5 to 7 years. And so you can see there's a number of these, and I'm only going to highlight a few of these that I think are doing a really fantastic job. There's many, many of these efforts. And so we have institutions and groups like the Antimicrobial Resistance Leadership Group. And so this is an NIH-funded research group that focuses on prevention, diagnosis, and treatment of antimicrobial resistant bacterial infections. And they have research and clinical trials in 19 countries around the world. And I've been a part of some of these efforts. And there's a large effort to make sure that we're not only representing what's going on in the United States, but we are representing globally what we're seeing in terms of these pathogens and how that might let us understand the dissemination of these pathogens and what might show up in your home country or your hometown in the future. There's also these CARBARU is what we call these because it's a mouthful otherwise. It's combating antibiotic resistant bacteria interdisciplinary research units. And these focus on discovery and validation of therapeutic, diagnostic, or vaccine targets. They focus on characterizing host factors and resistance mechanisms. And we actually have one of these in our home area here, and one of our TEPHI partners, Baylor College of Medicine hosts one of these six CARBARU sites as a part of these efforts. And so these are driving a lot of foundational research looking at understanding how these pathogens change across time and understanding how we can get in front of them to try to prevent these infections and treat them better. And then there's also institutions or groups like the Global Research in Antimicrobial Resistance, or GRAM group, which are responsible largely for a number of the slides I showed early on, looking at the estimates of the burden of antimicrobial resistance globally. And they're not only just looking at rates of resistance, but they're also, as an epidemiologist, doing some fantastic work that I haven't seen elsewhere, looking at a lot of the risk factors for antimicrobial resistance, both infections and dissemination, such as household crowding, antimicrobial consumptions, malnutrition. There's a number of these things that they're specifically looking at to try to understand how that builds into the establishment and spread of these resistant pathogens. And building on things like carbaryl and things like the ARLG, there's a large focus now on supporting development of alternative therapies and approaches. And by alternative therapies, I mean things that are not antibiotics. These are still heavily evidence-based, go through clinical trials, have a lot of effort behind them that show that they're effective. And these are broken down into a number of different categories. And all three of these are able to be given independently, but are often given in combination with antibiotics, at least currentty. And these are broken down into things like phage therapy, where we can think about viruses that infect us and infect humans that cause our infections. There are also viruses that target bacteria. We call them bacteriophages, and we can use those and basically introduce a virus that is specific to that bacteria, introduce it, and that virus will go and kill that bacteria and basically act as a treatment. And we're starting to see these be able to be targeted towards resistance bacteria. And in certain situations where someone has an infection that has no more antibiotics that can be used, it's pan-resistant to antibiotics, we have seen successful treatment of those infections with phage therapy, and we're seeing this continue to expand out. We've also seen a lot of focus on things like antimicrobial peptides, which, similar to how an antibiotic is us taking a product that another organism makes as a part of kind of microbial warfare and growth, and then use that as a part of our medical treatment. Instead of these being antibiotics, these larger molecules, these are just naturally occurring peptides that have activity against bacteria, viruses, and fungi that can be given as independent or a complement to antibiotics. And that's under this idea of kind of an adjuvant. When you give it as a combination and a complement to an antibiotic, that increases the effectiveness of the antibiotic. Then we call that an antibiotic adjuvant. And this is any compound or kind of product that can go through and enhance or restore the effectiveness of an antibiotic. And impactfully, some of these, we can think about when we have a penicillinase and you have that pathogen that you can't treat with penicillin, you can inhibit that penicillinase. It still produces it, it just isn't functioning. And then you can go through, and if you give them that penicillinase and penicillin side by side, you've restored the functionality of penicillin and allowed that bacteria to be treated with an antibiotic it otherwise would be resistant to. And so this extends the lifespan of our existing antibiotics. And so I think one of the really cool pieces, and there's only about 4 more slides here, and then we'll get to questions. But one of the really cool things that we're seeing out of this too is a lot of policy changes and a lot of approaches to really understand how can we better incentivize the development and the production of new antibiotics. When you think about your blood pressure medication drugs, when you think about drugs that treat any chronic condition that you can think of, when you develop it and you give it to somebody, you can give it to a large number of people, and often they take it for the rest of their lives, and it doesn't reduce in effectiveness over time. When you develop a new antibiotic, you can give it to people, but as you give it to more and more people, we see this emergence of resistance and they become less effective. And so the initiative now is not really to develop new antibiotics for a lot of these companies because your investment decreases the return across time. And so there's a lot of thought going into how to incentivize the development of these new antibiotics. And one of the more promising new models that is being put together is what we call the Netflix model of antimicrobials. And it's basically a payment plan where you give pharmaceutical companies a fixed payment, think $750 million or $1.3 billion to create an antibiotic. And this is often many countries going into this together or many populations going in this together. They give that money to then create the antibiotic. And then the incentive is that we don't have to use it and we don't have to sell it or use it to recoup that investment cost. And it sits there as a new last line until you absolutely need it. And so it's like Netflix. You're paying a certain amount of money every month. If you don't watch it, you don't watch it. But if you have, 1 month where you're snowed in or 1 month where you're on vacation and you watch 15 hours a day because you need to watch something, that's there for you, right? The same idea would be here. And we've had this proposed in the United States through the Pasteur Act that was not successfully funded, but I have hope in the future. And it's being piloted in the United Kingdom and Sweden to effectiveness where they've renewed this a few times to start to have these antibiotics developed across time. And they assure that we have new antibiotics in our pipeline to be available to us in the future. And then I think the thing that people often don't think about when they think about bacteria, because we often think about this in terms of kind of other pathogens, but Vaccines are effective against a wide range of different pathogens, bacteria, viruses. We see them all over, and we have a number of these that exist, but they're often underutilized. And so there was a recent report that came out from the WHO that focused in on the availability of 44 different vaccines against 24 different pathogens that are already available and underutilized or in late-stage clinical trials, and the effect that those vaccines may have in tackling this problem of antimicrobial resistance. And you can see that the existing vaccines are here. Some of the new targets are here. Gonorrhea is our through point throughout the entire lecture accidentally, but I'm leaning into it. And what you can see is that the projections here is that these vaccines would prevent up to 106,000 resistant deaths annually. It would prevent up to $861 million in hospital costs, $5.9 billion in productivity costs, and reduce, I'm sorry, this would be by 2050, not annually, by 2050. And they would reduce antibiotic use by 142 million doses by 2050. And again, the less doses we use, the more people that we keep healthy, the less impact personally there is, less impact economically there is, and the more value those antibiotics have because we've used them less. And these are incredibly impactful. And the last piece of our action plan here is to improve international collaboration and capacities for prevention, surveillance, control, and drug research and development. And so when we start to look particularly to our low and middle income countries and our partners globally, there's a push to continue to support and roll out pediatric vaccinations, similar to the idea of the PCV7 vaccination campaign in the Gambia. We want to continue to promote those. And the Gates Foundation puts a lot of effort into this. We want to invest in water, sanitation, and hygiene, that WASH infrastructure, because that is a massive complement. If you are taking away kind of the wastewater and all the different sanitation things, and you're enabling people to wash their food, to wash their hands, there's a lot less exposure to these pathogens and a lot less likelihood than of infections. And want to continue to support our infection control practices in our healthcare settings, and want to make sure that we have better availability globally of our antibiotics. We've seen across different time points, and particularly in the COVID pandemic, that supply chain issues have led to unavailability of antibiotics in certain parts of the world, and that when you don't have the antibiotic you want to use, you use something else. And this can then lead to emergence of resistance, emergence of pathogens, outbreaks, due to the lack of availability. And so there's a lot of effort into warehousing and storing antibiotics to make sure that we have that resiliency if something happens to the supply chain or we have something change in our pathogens, to be able to address it and keep those antibiotics available, particularly internationally where they're most at risk of those supply chain problems. And the last piece, and I think this is the brightest spot to me in addressing this antimicrobial resistant pandemic, is that we can adapt our current existing SARS-CoV-2 or COVID-19 monitoring infrastructure to address AMR. We spent a lot of time and a lot of infrastructure, and there is more expertise and sequencing capacity and informatics grouping and public health integration than there ever has been before in how we monitor and understand and characterize these pathogens. And a lot of these efforts, as COVID-19 funding winds down and as this becomes much more of a seasonal pathogen, are looking to adapt to something else or shut down. And I'm hoping we don't just shut them down. I hope we take them and adopt them to other efforts that are equally as in need of them. And I hope we start to see that these infrastructure be adapted to antimicrobial resistance. And this is going to require new laboratory methods, new informatics capabilities, and new expertise, and further public health integration, but it is possible. And this is a slide from the Scottish Pathogen Genomic Strategic Plan. This was something that they implemented about a year ago. And this is essentially just them taking all of their COVID-19 infrastructure and all of the work that they put into that and saying, what do we do with it? How do we expand this to make it better for the public's health and better enable us to address the future of infectious diseases? And they decided to turn this into a pan-pathogen kind of surveillance mechanism. But a lot of the effort here is on understanding and characterizing resistant pathogens, enabling clinical application of microbial genomics, and pushing this COVID-based technology revolution further into our response to pandemics and public health problems in the future. And within Texas, this is something we can do. We have TEPHI, which is where you're all here. We also have the Texas SARS-CoV-2 Variant Network, which is a public governmental private partnership across the state to collect and sequence and characterize SARS-CoV-2 positive isolates. We can start to move those efforts with appropriate funding and support to address things like our AMR emergence and the needs of this as we move forward. And I think this is the silver lining here. We see that the COVID pandemic led to this big increase again, particularly in our elderly, but we have the ability and the knowledge, and there's the interest in addressing this, and we need to get ahead of it. We need to make sure that we intervene now to try to prevent getting to those numbers in 2050. But I think more than ever with things like the infrastructure and the development of these different models that we've got across the globe, we are prepared for it. Now it's about acting upon that preparedness. With that, I do want to thank everyone for coming, and I'll open it up to questions.
Okay. First of all, if you, well, please see the evaluation form. There's also a website there if you're requesting CE credits. And I will leave this slide up so you can take a picture or whatever. The first question, Dr. Hanson, you showed a slide showing prescription for antibiotics, but do you know where Texas falls in the level of AMR impact or deaths compared to other states?
So off the top of my head, I know we're low, or we're not on the high end of antibiotic prescriptions, thankfully. I don't think we're kind of at the higher levels of what we're seeing for microbial resistance, but it's very different in different populations. And if we think about like our carbapenem-resistant Enterobacteriales, which is a large emerging resistant pathogen set, we have a lot of knowledge of what's going on in our city centers and our large population spaces. We don't necessarily know what's going on across the entirety of the state. So I think, we're in good shape in terms of what's there, but we do have spots where we don't have all of the information yet.
Great. Another question is pushback from health insurance companies on testing to identify the specific disease-causing microbe contributing to overuse or inappropriate use of antibiotics.
I think so. I mean, I think that when you start to look at how well you can diagnose what these different pathogens are, it gives you better information. And if you think about even differentiating different bacteria, they have different resistance profiles. We have different antibiograms that differentiate what you might want to choose for your antibiotic. A lot of it is cost and time. And so when we start to see those pushbacks, there's a diagnostic time. If you think currently the amount of time it takes from getting a swab to then sending that for culture to then sending it to get resistance typing, it can take 48 hours for most pathogens, up to days for things like TB. A lot of these technological changes, like that little laminar flow device that addresses virus versus bacteria, that small device then reduces inappropriate expending on antibiotics. It reduces, hopefully, the amount of people that end up in the hospital, those kind of things. I think we need to kind of value and reduce some of the cost barriers and then reduce the time. And then it will make these more effective in kind of the clinical process and make them more viable. And that's a big effort of what's going on with places like the ARLG. And a lot of these efforts is to try to overcome that barrier.
Another question, Loeb and McGeer criteria exist to help guide pre-prescription antimicrobial stewardship for UTIs. Do you know of anything similar for respiratory or skin infections?
Ooh, we're out of my wheelhouse here. That's very much on the clinical side. I am versed enough in it to kind of be dangerous, but I don't know if I could offer guidance on that. But I definitely know we have clinical partners that can give better advice there.
What are the unique challenges that border communities face regarding AMR and cross-border traffic for medical services?
Yeah, that's a big piece of this, right? And I think that it's not to stigmatize any of this, right? But I think when we start to look at our borders, particularly our state to state is okay, then international borders, we see that we don't always know what's going on internationally in terms of what's circulating in those pathogens. And we do see people sometimes go for medical treatment and come back. And I wouldn't even say it's necessarily borders. It can be airports at the site of borders as well. And this is a part of dissemination. When we look at SARS-CoV-2 dissemination, we see a lot of it was associated with travel, with kind of other pieces around that. So we need better representation. And this is why it's so important to invest in the global aspect of this monitoring, to know what's circulating in those locations and know what's around so that we can better then look for it here. If we don't know it's out there in the globe, we also don't know to look for it here.
And one last question, because we're out of time. Antimicrobial, I can't say that word, antimicrobial prescription durations. Do MDs have a resource for optimal duration?
Absolutely. And so this is like where things like IDSA's guidelines come into play. There are a lot of groups out there that will give better guidance on this than I ever could. But IDSA has a lot of descriptions of duration, of prescriptions, and how to deal with some of these particularly recalcitrant resistant pathogens. And it gives you a lot of the indications of what's going on there. And so I think I would direct you towards societies like that focus specifically on that.
All right. Thank you very much. Thank you, everybody, for attending. Please fill out the survey, and we will see you in January. Email us if you have suggestions for future topics. and have a good evening. Bye-bye.
Thanks, everyone.